Poliomyelitis is an acute viral infection. Upon entering the body, the virus specifically targets the central nervous system, infiltrating neural pathways and destroying the motor neurons that control muscle movement, leading to irreversible paralysis. Before global eradication efforts began in earnest, this disease crippled hundreds of thousands of children annually. Wards filled with iron lungs and heavy metal leg braces were standard fixtures of mid-century pediatric medicine. By 1999, the global incidence of polio had decreased significantly. An estimated 350,000 cases in 1988 dropped to fewer than 20,000, a 95% reduction in just over a decade. The primary pharmacological engine driving this mass reduction was the oral polio vaccine, or OPV. As eradication efforts pushed the wild virus into a corner, public health officials encountered a specific epidemiological paradox. OPV carries an intrinsic biological mechanism that allows it, in rare instances, to cause the exact paralytic disease it was engineered to prevent. Finalizing the global eradication of polio requires navigating this biological trade-off. The most effective tool for stopping wild poliovirus becomes the primary source of the disease itself. The oral vaccine utilizes the Sabin strain, a live, attenuated, or weakened form of the poliovirus administered via liquid drops. This stands in direct contrast to the older technology, the Salk strain. This formulation uses a poliovirus that has been chemically inactivated with formaldehyde and is administered through an intramuscular injection. Modern health technology assessments evaluate these two competing architectures across three parameters. First, clinical efficacy, then safety profiles, and overall program effectiveness. The core biological distinction separating these vaccines is how they arm the host. Policymakers must weigh the value of systemic immunity, which operates in the blood, against mucosal immunity, which operates in the lining of the gut. Policymakers do not simply choose a superior drug. They must identify which immunological architecture matches the precise epidemiological threat level of a specific population. OPV's dominance in developing nations begins with its delivery. It requires no syringes and no highly trained medical staff, just a few drops placed directly into a child's mouth. Because it's a live attenuated virus, OPV travels down the esophagus and enters the gut lumen, mimicking the natural infection pathway of wild poliovirus. This triggers a dual-action immune response. Systemic antibodies fill the blood, while specialized immune cells deploy directly along the intestinal wall, creating a localized mucosal barrier. To quantify this efficacy, the World Health Organization conducted a large, multi-center randomized controlled trial across Brazil and Gambia, tracking 1,409 infants. The results documented distinct seroconversion rates across the three viral strains: 85% for type 1, 94% for type 2, and 68% for type 3. These rates fluctuate in developing nations. Clinical data indicates that concurrent diarrheal diseases, as well as the presence of other non-polio enteroviruses in the digestive tract, actively interfere with the vaccine's ability to establish immunity. There is also internal biological friction. During intestinal replication, the Sabin type 2 strain actively suppresses the host's immune response to the type 3 strain. This dynamic ultimately lowers its specific efficacy. However, OPV offsets these individual failures through a phenomenon called secondary contact immunization. Because the virus multiplies in the gut, the vaccinated child sheds the attenuated strain, unintentionally immunizing household and community contacts. This is OPV's strategic advantage. It utilizes the virus's own natural transmission route to establish mucosal herd immunity across highly endemic regions. That epidemiological reach carries a documented cost: vaccine-associated paralytic poliomyelitis, or VAP. According to multi-center cohort studies, this severe adverse event occurs at a rate of approximately 1 case for every 1.5 to 2.2 million doses administered. VAP is driven by viral retromutation. As the live Sabin strain replicates within the human host, its RNA strand occasionally introduces a structural mutation. This shows what happens when that mutation strips away the Sabin attenuated phenotype. The virus regains its original neurovirulence, breaches the intestinal barrier, and attacks the central nervous system. Clinical observation has also identified provoking factors. Receiving unrelated intramuscular injections within 30 days of OPV exposure measurably increases the risk of triggering this vaccine-associated paralysis. This specific risk is absent from other vaccine architectures, which rely on inactivated viral material. The characteristic that makes the oral vaccine effective at a population level, its ability to replicate live virus in the human gut, creates a biological vulnerability for the individual patient. To eliminate that risk, medical systems utilize the inactivated polio vaccine, or IPV. This requires a different delivery method entirely. Returning to our evaluation matrix, we see how IPV operates. It utilizes the formalin inactivated Salk strain, bypassing the digestive tract completely, to deliver dead viral antigens directly into the muscle tissue. The clinical efficacy is high. IPV drives systemic seroconversion rates ranging from 90 to 100% across all 3 poliovirus types, filling the bloodstream with neutralizing antibodies. Because the virus is inactivated, it cannot mutate. IPV eliminates the risk of vaccine-associated paralysis. Adverse events are restricted to minor local reactions at the injection site, like mild erythema or a slight fever. But this systemic shield has a critical clinical vulnerability. IPV fails to induce functional mucosal immunity. If wild-type poliovirus is ingested, bloodstream antibodies will block it from reaching the nervous system, but the virus can still multiply within the unprotected intestinal lining. This creates a major epidemiological blind spot. An IPV-vaccinated child is immune to paralysis, but they can still act as an asymptomatic carrier, shedding contagious wild virus back into the community. Early randomized trials demonstrated exactly this. When deployed alone during active outbreaks, IPV proved inadequate at limiting intestinal infection or halting community-wide transmission. While the inactivated vaccine protects the individual patient from harm, its failure to break the chain of transmission makes it an insufficient standalone tool for eradicating the disease in highly endemic zones. Recognizing the isolated flaws of both OPV and IPV, global health authorities shifted their focus toward combined immunization schedules. A collaborative study across Gambia, Oman, and Thailand proved that administering IPV alone at 6, 10, and 14 weeks of age failed to provide adequate overall serological protection in these environments. The proposed solution, mapped here on this timeline architecture, was a sequential schedule merging both methodologies. It begins with IPV administered in the first 2 infant immunization slots. These initial IPV injections build a systemic antibody shield in the blood, free from the risk of vaccine-induced paralysis. Once that systemic shield is established, oral drops are introduced. The live attenuated Sabin virus enters the gut to build the missing mucosal barrier. Even if it mutates, the pre-existing IPV antibodies in the blood block it from reaching the nervous system. Clinical studies in 1997 confirmed the efficacy of this approach. Sequential administration successfully achieved both optimal humoral immunity in the blood and mucosal immunity in the digestive tract. By front-loading the inactivated virus, the host establishes a baseline defense that neutralizes the paralytic risk of the subsequent live virus doses. The sequential schedule creates a specific immunological synergy. It utilizes the inactivated vaccine to neutralize the oral vaccine safety risk, while utilizing the oral vaccine to patch the inactivated vaccine's epidemiological blind spot. These clinical findings dictate how national health ministries structure their defense grids. Immunization schedules cannot remain static. They must respond to real-time data. As this flowchart illustrates, a nation's policy is dictated by a calculated risk-benefit ratio, weighing the threat of wild-type virus circulation against the risk of vaccine-associated paralysis. In environments with high wild-type circulation, the threat of natural infection outweighs the rare risk of a vaccine adverse event. The flowchart routes directly to an OPV-only strategy to prioritize mucosal herd immunity. As wild-type polio approaches eradication, the math flips. The wild virus disappears, and the vaccine itself becomes the primary cause of paralysis. The routing path shifts away from the oral drops, funneling into a sequential or IPV-only framework. Health technology assessments recommend that pure IPV-only schedules be deployed in fully eradicated zones, or reserved for immunocompromised patients who cannot tolerate live vaccines. Eradicating a global pathogen involves a dynamic pharmacological architecture, one that must adapt to the shifting statistical realities of the battlefield.